Bismillahirrahmanirrahim. Allahumma salli ala Muhammad wa ali Muhammad. Dr. Rahim Mahal. My topic is kidney cancer, metastatic renal cell carcinoma. Okay, renal cell carcinoma is a kidney cancer. It is the most common type of kidney cancer. It is the malignant tumor. Renal cell carcinomas originate in the cortex and tend to grow out into perinephric tissue, causing the characteristic bulge or mass effect that aids in their detection by diagnostic imaging studies. It accounts for approximately 3% of adult solid malignancy, 51,000 cases diagnosed, and more than 12,900 deaths annually in the US. It firstly described by Canning in 1826. All these tumors arise from renal tubular epithelium. It accounts for 80% to 85% of kidney cancer. It is the 2% to 4% increase in incidence per year. Okay, the epidemiology of renal cell carcinoma. It is the male predominance. Male-female ratio is 1.6 proportional to 1.0. Renal cell carcinoma occurs most commonly in 5th to 6th decade. The highest incidence between age 50 to 70 years, and the median of diagnosis is 66 years, and the median age of death is 70 years. The majority of renal cell carcinoma occurs sporadically, and the highest incidence in Scandinavia and North America, and the lowest in Africa. While the incidence of renal cancer may vary based on race, black men demonstrating a higher incidence than in men of all other races, Asian appears to have the lowest incidence of renal cell carcinoma. These are the risk factors. Number one, tobacco. Smoking contributes to 24 to 30% of renal cell carcinoma cases. Tobacco results in a twofold increased risk. The environmental is cadmium, sodium dioxide, petroleum, and pan-acetane analgesics. The occupational is leather tanners, shoe workers, asbestos workers, and the hormonal is diethylstilbestrol, and obesity and hypertension also. 35% to 47% patients on long-term dialysis develop acquired polycystic kidney disease, out of which 5.8 develops renal cancer. Okay, natural history. 27% diagnosed incidentally. Of them, 45% present with localized disease, 25% with locally advanced disease, 30% with metastatic disease. Lymph node metastasis is 9% to 27%. For example, para-aortic paracavus and renal enlargement. And the percentage of renal vein is 21%, and the inferior vena cava 4%. While distant metastasis, lung 75%, bone 20%, liver 18%, and skin 8%, and CNS also 8%. And the clinical presentation. Flank pain, hematuria, palpable abdominal mass is a classic triad. Classic triad occurs only in 5 to 10% of patients, and the symptoms are anemia, fatigue, cachexia, weight loss, hypercalcemia, and hepatic dysfunction. Okay, paraneoplastic syndrome. It is a rare disorder that are triggered by an altered immune system response to a neoplasm. Renal cell carcinoma is associated with a wide spectrum of paraneoplastic syndrome, including hypercalcemia, hypertension, non-metastatic hepatic dysfunction, and parathyroid-like hormones, erythropoietin, renin, gonadotropins, placental lactogen, prolactin, enteroglucagon, insulin-like hormones, adrenocorticotropic hormones, and prostaglandins identified in renal cell carcinoma patients. Okay. Renal cell carcinoma occurs in two forms, inherited and sporadic. Here, the hereditary forms of renal cell carcinoma have been described. Hereditary renal cancer syndrome. It is the inherited forms of renal cancer are estimated to account 2 to 6% of all kidney cancer. Currently, 10 inherited cancer susceptibility syndromes are definitively associated with an increased risk of renal cancer. Patients with these inherited syndromes develop kidney cancer at an earlier age. Furthermore, the lesions can be multifocal, bilateral, and heterogeneous. Several syndromes have renal cancers as a primary features, including Bird-Hodge-Tube syndrome, familial clear cell renal cancer due to chromosome 3 translocation, and the hereditary papillary renal syndrome. And hereditary papillary renal syndrome, it was described in 1994. It's characterized by a predisposition to develop multiple bilateral renal tumors with a papillary histologic appearance. And number 4, hereditary leiomyomatosis and renal cell cancer. And last one, von Hippel-Lindau disease. It is a familial cancer in which syndrome affected individuals with a mutation of chromosome 3p predisposition to develop tumors in multiple organs, including cerebellar hemangioblastoma, retinal angiomata, and bilateral renal cell carcinoma. Diagnostic workup. How to evaluate patient? Evaluate the patient by diagnostic workup and metastatic workup and others. Now come to diagnostic workup. First of all, we take history of patient and physical examination, then laboratory studies like CBC, LFTs, alkaline phosphatase, blood urea nitrogen, creat, and urine analysis. Then we go to radiographic studies. It is the increased use of imaging has increased the detection of renal lesions. Number 1, ultrasonography. Number 2, computed tomography and MRI. Ultrasound examination is invasive, relatively inexpensive technique. Is approximately 98% accurate. It is excellent in distinguishing cystic from solid masses. And computed tomography provides an excellent assessment of the parenchyma and nodal status. While CT scan is more sensitive than ultrasound for detection of renal masses. And the magnetic resonance imaging, MRI is equivalent for CT scan for staging of renal cell carcinoma. It is the excellent demonstration of solid renal masses and is image test of choice to demonstrate extent of vena cava involvement with tumor. It is the useful in patients with renal insufficiency. Then metastatic workup. First of all, we do chest CT and then CT MRI scan of the abdomen and pelvis, then radionuclide imaging, bone scan with plain films. It is only for the patients with elevated alkaline phosphatase or bone pain and very low incidence of bone metastasis and others. Other tests we also do renal angiography.
Just a word about this investigative protocol. If you go back to the previous slide, uh, if there is no, need the other one, one forward. Yes. Uh, you have written that bone scan should be done for the case of metastatic workup. Now, if there is no history of bony pain and no evidence of anything involving the bone, then the metastatic workup normally doesn't include bone scan. If you compare this thing with, for instance, a case of prostate cancer, then bone scan is always done in order to judge whether the metastatic potential of the tumor has gone on to the stage of bony involvement. But for bladder tumors as well as for kidney tumors, bone scan is not done as part of the routine protocol. It is done for those cases. Again, I'm just repeating myself. For those cases who have got bony pain, or when you have got a doubt whether there is any fracture along with the presence of a renal tumor, and that fracture may be the cause of metastasis. Um, so it is not done routinely. If you go on to the next slide, please. Yes. Now PET scan. Now PET scan normally is not done for the purpose of diagnostic workup primarily. Primarily means that it is not done for the very first time. It is always done for some cases whenever you have got a doubt after the treatment has been given, whatever the treatment may be. For instance, if you want to see whether there is any recurrence, then for the purpose of seeing the recurrence, then PET can be explored. But this is not something which is again part of the routine protocol of doing the investigation.
Okay, right. There are two figures. Figure 1, computed tomography demonstrates a right renal cancer with a large contralateral adrenal metastasis. And there is a figure 2, CT scan shows a large left renal mass invading the left renal gland. Arrow shows left renal. Okay. TNM staging.
If anybody wants to say anything, just please raise your hand so that we can ask or involve the person. If anybody wants to say anything at this stage? No? Yeah, please proceed.
Okay, sir. TNM staging, the ultimate goal of staging is to select appropriate therapy and obtain prognostic information. It is the study for a complete clinical staging evaluation include history, physical examination, CBC, chest X-ray, CT scan of the abdomen and pelvis, and chest CT scan. And the original system described by Robson in 1963, it is easy to use, but it doesn't relate directly to prognosis. Hence, it is no longer commonly used. The TNM system more accurately classifies the extent of tumor involvement and is currently most often used. Now for T for primary tumor, N for regional lymph nodes, M for distant metastasis. Tx for primary tumor cannot be assessed. T naught, no evidence of primary tumor. T1, tumor 7.0 centimeter or less in greatest dimension but limited to 50. And T1 is further divided into T1A and T1B. T1A, tumor less than 4 centimeter but limited to 15, and T1B, tumor in between 4.0 to 7.0 centimeter, also limited to 15. And now T2, tumor more than 7.0 centimeter. And T2 is further divided into T2A and T2B. And T2A, tumor less than 7 centimeter but greater than 10 centimeter. And T2B, tumor greater than 10 centimeter but limited to 15. Okay, T3 is further divided into T3A, T3B, and T3C. And T3 tumor extend into the major veins or perinephric tissue, but not into the ipsilateral vein or beyond Gerota's fascia. T3A, tumor invades renal vein or its segmental branches or perirenal thread or renal sinus thread, but not beyond Gerota's fascia. And T3B, tumor grossly extend into the vena cava, but below the diaphragm. And T3C, tumor also extend into the vena cava, but above the diaphragm. And T4, tumor invades beyond Gerota's fascia, including contiguous extension into ipsilateral adrenal gland. And for regional lymph node, NX, regional lymph nodes cannot be assessed. And N naught, no regional lymph node metastasis. N1, metastasis in regional lymph node. M for distant metastasis, MX, distant metastasis count cannot be assessed. M naught, no distant metastasis. M1, distant metastasis. Here is staging of renal cell carcinoma. There are four stages of renal cell carcinoma. Stage 1, renal cell carcinoma is confined to the kidneys, and stage 2, renal cell carcinoma extends through the renal capsule but is confined to Gerota's fascia. And while stage 3, renal cell carcinoma involves the renal vein or inferior vena cava, tumor 3A, or the renal hilar lymph nodes, tumor 3B. While stage 4, renal cell carcinoma has spread to local adjacent organs other than adrenal gland or to distant sites. Okay, stage 1 to 3 is a localized disease, and stage 4 is an advanced metastatic disease. In stage 1, the 5-year survival rate is 95%. In stage 2, the 5-year survival rate is 88%. In stage 3, the 5-year survival rate is 59%. In stage 4, the 5-year survival is 20%. Okay, this is the stage 1, 2, 3, and 4. Okay, this is a tumor, but less than 7 centimeters, but limited to the kidney. stage 2, tumor greater than 7 centimeter but limited to the kidney. And in stage 3, tumor extends into the major veins or perinephric tissue, but not beyond sclerotas fascia and adrenal ipsilateral gland.
Yes.
In stage 4,
Uh, you just complete and then I'll add something.
okay, sir. In stage 4, tumor is a big in size and invade into the sclerotas fascia as well as to other organs and ipsilateral adrenal gland.
Right.
So,
Right. So I want to add one thing at this point is um, there has been a lot of change in understanding the natural history of kidney cancer over the past many years. And now we are, at one time, it was said that if this tumor is there and you are a doctor dealing with this tumor, then you have got only one option, and that is to make yourself comfortable in making a decision whether the person can be easily uh, managed by surgery or not, because there is no other treatment. Renal cell carcinoma is not chemosensitive, renal cell carcinoma is not radiosensitive. So that was the actual philosophy behind. So whatever you want to do or you can do is only in terms of surgery. Now, for that matter, as you have seen in stage 4 and stage 3, there is a thing called thrombus, and that thrombus is going from the renal vein into the inferior vena cava.
right.
If it might be unilateral, it might be bilateral, it can be on right side, it can be on left side. Now, on the basis of complexity of surgery and the complexity of tumor anatomy, this tumor thrombus has been divided into different levels, level 1, 2, 3, 4, and that depends upon the involvement of vena cava, whether it is supradiaphragmatic, infradiaphragmatic, confined to the renal vein, or confined to the infrahepatic portion. And on that basis, the whole procedure is being planned. Now, with the understanding again of this natural history of the tumor, now there are some important interjections into the management, and these were some drugs which are being used in the setting, which is a new adjuvant setting. And there is a very big trial which hasn't been concluded, but it gives some important messages, and that trial is known as Carmina trial. And the actual message or the objective of that trial is uh, this tumor which was once regarded as chemo resistant now a, is a tumor which, with the advent of certain drugs, can be managed uh, by means of chemotherapy, and the results are as good as having surgery. Now there is a new paradigm, and this new paradigm also culminates in having stage, say, process. For instance, whenever you do staging, staging protocol, you always stage in two terms. One is the clinical stage, in which you take into consideration certain investigations like CT scan, MRI, and then you do your clinical assessment. The other thing is known as the pathological staging, and that staging is after you have taken the biopsy or after you have taken out the tumor. So a pathological stage is different from a clinical stage. Now, in the context of renal tumor, if you do something in a new adjuvant setting, which means that before surgery you prescribe some drugs, then that staging will be regarded as something which is for new adjuvant chemotherapy. So now there is another class of staging which has been added before clinical staging. So when you study this chapter of metastatic renal tumor or simply organ confined renal tumor, then you have to study staging process in three stages. One stage is pre-surgery, the other one is surgical, and the third one is post-surgery. So in that way, you will be able to understand properly. Yes, please proceed.
These are the prognostic factors for renal cell carcinoma. Pathologic stage, tumor T1 to T2 organ confined. The 5 year survival is 70% to 90%. If tumor T3, the 5 year survival is 50 to 70%. In lymph node, regional lymph node and distant metastasis, the 5 year survival is 5 to 30%. Tumor size. If tumor less than 4 centimeters, the survival is greater than 90%. If tumor in between 4 to 10 centimeters, the 5 year survival is 50%. If tumor greater than 10 centimeters, the 5 year survival is 0%. Renal cell carcinoma is classified on the basis of histological type. Number one, clear cell carcinoma. The 5 year survival is 70%, and papillary and chromophobe, the 5 year survival is 85%. And multilocular cystic, the 5 year survival is 100%. And last one, medullary and collecting duct, the 5 year survival is 0%. Renal cell carcinoma is not one disease. It is made up of number of different types of cancer with different histology and caused by different genes. Like clear cell RCC, papillary type 1, type 2 RCC, chromophobe RCC, and oncocytoma RCC. The incidence of clear cell is 75%, and associated mutation gene is THS, one Kipling gene. And the papillary type 1 and type 2 incidence is 5% and 10%, and the gene is c-MET, and the papillary type 2 gene is FH, fumarate hydratase, and the chromophobe incidence is 5%, and the oncocytoma incidence is 5%, and both are associated gene with BHD, bird huge tube, bird Hodge tube. The cells of the clear cell renal cell carcinoma are rounded or polygonal with abundant cytoplasm which contains cholesterol, triglycerides, and glycogen as well as lipids. The cells present in papillary type 1 and type 2 are polygonal, less glycogen and less lipids, and granular cytoplasm contains many mitochondria and cytosomes. And the chromophobe type carcinoma contain large polygonal cells with distinct cell borders and reticulated cytoplasm, while oncocytomas cytoplasm packed with the mitochondria, giving it a granular appearance.
Now, this slide is very important, and I think this summarizes the whole topic of renal cell carcinoma as such. Because you see, if this slide stays in your mind, then whenever you read the report after you have done surgery, then you will be able to understand a lot of things. You will be able to understand the hereditary potential, for instance. You will be able to understand the malignant potential, the metastatic potential, rather. So there are many things that can be easily understood. So please keep this slide in your mind. This is a very important slide.
Differential diagnosis. A variety of lesions in the retroperitoneum and kidney other than renal cyst may stimulate renal cancer. These include lesions due to hydronephrosis, adult polycystic kidney disease, tuberculosis, xanthogranulomatous pyelonephritis, metastatic cancer from another primary cancer, and angiolipoma or other benign renal tumors or adrenal cancer, and retroperitoneal lipomas or sarcomas as well as abscess. The management is localized disease and metastatic disease. The management of localized disease. Nephron sparing surgery. It is a kidney surgery where only part of kidney is removed. It is most often performed as the first step in the treatment certain types of cancer. It is a gold standard treatment for localized RCC. Indications are bilateral renal cell carcinoma, renal cell carcinoma in a solitary functioning kidney, and unilateral RCC with contralateral kidney under threat of its future function. For example, renal artery stenosis, chronic pyelonephritis, hydronephrosis, ureteral reflux, calculous disease, and systemic disease such as diabetes. Number 4 point, tumor less than 4 centimeters with normal opposite kidney. And the 5-year survival rate is 75% to 85%, while local tumor recurrence of 10% is reported. This is the picture of partial nephrectomy. This is a tumor, and this is the picture of partial nephrectomy. Removes disease of tissue from kidney and leaves healthy tissue in place. Kidney close. And radical nephrectomy. Radical nephrectomy is the primary treatment for localized RCC. Its goal is to achieve the removal of tumor and to take a wide margin of normal tissue. And the principles of surgery is the early ligation of renal artery and vein, removal of kidney including Gerota's fascia, plus removal of ipsilateral adrenal gland, regional lymphadenectomy from cuts of diaphragm to aortic bifurcation. This is the picture of radical nephrectomy. This figure shows boundaries of a left radical nephrectomy. Dotted lines represent both surgical margin and Gerota's fascia. And laparoscopic radical nephrectomy and partial nephrectomy can also be accomplished successfully and safely. Laparoscopic radical nephrectomy is being used increasingly for patients with localized renal tumors. And this approach results in quicker recovery with efficacy comparable to that of open radical nephrectomy and is now the approach of choice in appropriate patients with less than 10 centimeter tumors and without local extension or a renal vein or caval thrombus. And the role of RT radiotherapy, potential benefit of radiotherapy in selected cases where there is a high risk of local failure. Preoperative RT in resectable, locally advanced tumors, including tumor T3A and tumor T3C. While tumor T3B, vena cava invasion doesn't necessarily increase risk of local failure. Post-op in cases with incomplete resection with positive margins are found to have lymph node involvement. RT in these cases may improve local control but probably not overall survival. Its play a role in palliation also.
Right. If you go back to the slide which is on the definition of radical nephrectomy, just there, the figure, the other one, yes, this one. You see, it says that you have to take the whole kidney along with the adrenal gland, Geroda's fascia, and the template of lymph nodes, which is actually draining that part of the kidney, that side of the kidney. Nowadays, this has been modified. Modified in the sense that if, for instance, the tumor is not close to the upper pole and you want to take out the whole kidney or you want to do a partial nephrectomy, then you don't have to take out the adrenal gland. One thing. The second thing is all the lymph nodes need not to be taken out. Those lymph nodes which are actually obvious on CT scan, meaning to say greater than 1 centimeter, or they are palpable. Palpable whenever you open up the kidney, or you open up the space, and you see in front of your eyes that there is a big lymph node. Now, how big it is, it again depends uh, upon your own perception. So, if there is evidence of bigger lymph nodes, then those lymph nodes should be taken out. Otherwise, the whole template these days is not taken out, because if the lymph nodes are not taken out, as compared to cases where the lymph nodes are taken into consideration, then there is no difference in results. So that was the actual impression, which leads to a little bit of violation of this definition, which includes the template of lymph nodes as well as all the structures. So at the moment, what practically is being done is we do radical nephrectomy. We do take the adrenal gland if it is involving the upper pole or it is very close to the upper pole and there is a high suspicion that adrenal might be involved. We take out whole thing within Geroda's fascia. We take out all the perinephric fat along with it, but we tend to leave behind the lymph node chain if it is not again palpable or obvious. So obvious things are taken out, the non-obvious things are left as such. So this is the actual position practically which is there. Whenever you are doing something called a laparoscopic nephrectomy, then again it would be rather easier to take out a tumorous kidney than to take out a kidney which is an infective kidney. The reason is an infective kidney is actually very much adhered to the surrounding structures. So whenever you take out, you actually are shaving out the kidney along with some of the structures which are stuck to the, for instance, the psoas muscle or the psoas fascia, and all the structures which are in the periphery of that kidney. So uh, normally what we see is a tumorous kidney is not an infective kidney normally. It can be an infective kidney, but normally it doesn't. So a tumorous kidney is an easier thing to just dissect as compared to an infective kidney. So this is one point, a practical point which can be added. Uh, these tumors are also taken out by means of robotic surgery, but robotic surgeries are nothing but advanced laparoscopy. So the principles hold their place. You do open surgery, you do laparoscopy, you do advanced laparoscopy, which we call robotic surgery. Please proceed. Now, if there is any point which anybody wants to raise the hand, and then we can discuss at this stage. Now, everybody is listening. Everybody can talk.
Yes, sir.
Right. So, yes, Shesha, you want to add something here? Yes, please go on.
Sir, Assalamu alaikum. I'd like to ask the extent of ureterus fascia. Is it down to the end of ureter and it involves the removal of all the ureter as well?
See, practically, it involves the upper one third of ureter, and this is the same place where the actual Hasselbeck triangle is. This Hasselbeck triangle is between the lower pole of the kidney and the upper one third of the ureter, and it has got the mesentery in which the vessels supplying the upper part of the ureter is actually running. So Geroda's is almost there. It ends vaguely somewhere in the middle of the ureter.
Right. Thank you. Management of metastatic disease. The management of metastatic disease is surgery, radiotherapy, chemotherapy, targeted therapy, and immunotherapy. For surgery, palliative nephrectomy, it is indicated in patients pain, compression of adjacent viscera, solitary metastasis can be resected and may show some survival advantage. And therapeutics. Not curative but may produce some long-term survival. The possibility of disease-free survival increases after resection of primary tumor and isolated metastasis excision. It is to decrease tumor burden in the preparation of subsequent therapy. And resection of metastasis in patient not relieved from palliative radiotherapy and in solitary metastasis. Radiotherapy. Only palliative. It is used for local or symptomatic metastatic disease such as painful osseous lesions or brain metastasis. It is the treatment field encompasses metastatic deposit or local recurrence with 2 to 3 centimeter margin and also higher doses up to 35 to 40 grams may be required to overcome radio resistance. It is a symptomatic relief in 64 to 84% of patients. And chemotherapy, renal cell carcinoma is a chemo-resistant tumor phenomena due to the presence of multi-drug resistant glycoprotein in tumor cells. It causes the extrusion of the drug. conventional therapy but has little to offer. 5-fluorouracil alone has a response rate of 10% and ongoing clinical trials of combination. Targeted molecular therapy. It is the new treatment approach that targets only the cancer cells. In renal cell carcinoma patients, this type of therapy uses drugs that stop the new blood vessels from growing and targets certain factors that cause the cells to grow. Like tyrosine kinase inhibitors, it blocks the intracellular domain of vascular endothelial growth factor receptor, like sunitinib. The sunitinib brand name and the sorafenib, brand name is hexamol.
Right.
And
Yes, please continue, please.
and monoclonal antibody that binds circulating vascular endothelial growth factor and it prevents the activation of vascular endothelial growth factor receptor like avacitinib. The brand name is Avastin. And mammalian target of rapamycin inhibitors like TMSR.
Right. So I want to add one thing here. Yes, so we understood the phenomena that chemotherapy has got a very little role in the management of renal tumor, but this targeted molecular therapy has got a very big role. And the data is supporting the evidence that it can be used in comparison to surgical management. Now, the results which are coming up is if you have got a patient with metastatic RCC, so before going towards surgery, if you start those people who are having metastatic disease on, for instance, sunitinib, then there are very good results. They can not only downstage but also downgrade the tumor. And after a little while, if you do surgery on these patients, then again surgery will be of much benefit. So now, in the context of renal tumor, we have got a lot of things to play with. The tyrosine kinase inhibitors, the mTOR inhibitors, and the VEGF blockers. Uh, Certain other things are also coming up which are not in this list. And when these will be available, then this tumor has got a very strong potential and interest uh, of again a combined approach towards management. Combined approach means approach which is not only guided by a surgeon but also guided by a physician. As far as the radiotherapy is concerned, radiotherapy has got a palliative role, if at all it has got a role. The palliation is for those tumors that have been taken out, but those were actually going into the surrounding tissues, and then there is a recurrence in the renal bed. Now, these are the cases where you want to do away with something uh, preemptively, and these are the cases where you do radiotherapy. Now, there are certain cases where renal cell carcinoma, clear cell variety is not there, but rather than they will have something called squamous differentiation or squamous cell carcinoma of the renal pelvis. Now, again, if the kidney is taken out with histological reports saying that squamous cell carcinoma or transitional cell carcinoma, then these are the cases which are rather sensitive towards radiotherapy. So, radiotherapy again has got, I just repeat myself, a role in palliation, not as something which is definitive.
Immunotherapy. It is the systemic type of treatment used to improve the body's natural defenses. It boosts the immune system and slow down the cancer growth and clinical response to immune therapy seen in patients with good performance status and a prior nephrectomy and non-bulky pulmonary or soft tissue metastasis and also asymptomatic patients. Summary. Renal cell carcinoma is relatively uncommon but increasing incidence. It is associated with tobacco and inherited disorders. Surgery is the only curative modality for stage 1, 2, and stage 3. Renal cell carcinoma is radio-resistant tumor. RT's role in palliation and stage 4 disease hold poor prognosis despite advancements in molecular understanding. Interleukin-2, sorafenib, sunitinib, and TMSR are FDA-approved treatments for advanced RCC. These are the references.
Right.
Thank you.
Right. Very good. Thank you very much. So if you go back to the slide which summarizes the whole thing. Now, I'm very much comfortable with everything except this, the third point, which says that surgery is the only curative modality for stage 1, 2, and 3. Now, surgery is now in question. Now, it is something which has to be taken with a pinch of salt. It is a statement which can be taken as such 10 years back, but not now. Science is changing too fast. We have got a lot of treatments available. And just to make you understand what the ground situation is, uh, this topic of neoadjuvant therapy before surgery was discussed amongst us in our MDTs and our tumor boards. Just 3 years back, this was a topic which was not of any interest to a lot of people, particularly our medical oncology um, colleagues. But now we have got a separate clinic on every Wednesday only for those people who have got metastatic RCC and who are actually on sunitinib. So we have now, just 3 years down the line, in 2020, maybe in middle part of the last year, the 2019, we have devised a separate clinic for these patients. This is again a testimony to the fact that this is something which has got a role, which has got a positive effect on dealing with patients where on the contrary they don't have anything. For instance, if there is a tumor thrombus in the vessel and there is a tumor metastatic focus in the lungs and also in the bones, then these are the patients, if you take out the kidney, those tumor foci will not go away. Now there is a treatment which is available for them before doing any surgery. So now the whole gamut of management of renal tumor is again changed from the perspective of the textbook also. Maybe if you read the textbook, which has got a publishing date 5 years back, it will not tell you all these things. But now the newer books will always take into consideration a lot of new things also. So I just impress upon you to read all these lines again with the perspective which is very much in front of us, and that is something which is different. So if anybody wants to raise any point here, any clarification needed,
Sir, I would like to ask one thing.
please identify yourself.
Sir, I'm Abdul Rafi.
Right.
My video is, I guess,
Yes,
stopped from the host side. Okay. In one of the tumor board meeting, we talked something about a renal nephrometry score and its role in selecting a surgical. What is this nephrometry score? And
right, you see, whenever you see a tumor, it is or whenever you see any gland, any anatomical structure like a kidney, it is a bean shaped structure. And if we do an ultrasound or a CT scan, it's a two-dimensional picture. Now that two-dimensional picture, it will always give you a dimension in two axes. One is the x-axis, the other one is the y-axis. But we are actually missing the depth of the structures unless and until we rotate the picture. So normal investigations always give you a two-dimensional picture, whereas in actuality, a tumor or anything has got another dimension which is actually imaginary in the mind of a surgeon or any clinician. Now, this nephrometry score takes into consideration the whole three-dimensional configuration of a tumor. A tumor may be of a bizarre shape. It may be of a stellate shape, or it may have any shape which is different from normal geometry. It can go on into the deeper planes of the kidney on another dimension which is not in front of you whenever you see a CT scan, for instance. So nephrometry score takes into consideration again the complexity of the configuration of a tumor within a normal structure, anatomical structure. For instance, if there is a 4 centimeter tumor, and your staging process always takes into consideration only the 2 dimensions. If there is a 4 centimeter tumor at upper pole or at a lower pole, the indication is you must do partial nephrectomy. But this 4 centimeter tumor may be very close to the renal hilum. It may be very close to the vascular structures. It can be closer to the surface, which means it is exophytic. It may be in the depth of the surface, which may be endophytic. So there are these considerations which, once taken into perspective, gives you a score. This is one way of understanding it, and that is known as nephrometry score. The second thing is, it will also give you something called digitalization of understanding something which is in the form of a text. Now, at the point we are doing surgeries on 2 platforms. One is the open platform, which is like we do in our theaters. The other one is the laparoscopy, and as I've said earlier on, the third one is the robotic. All these 3 platforms are actually making yourself as a surgeon away from your patient. When you do open surgery, your hands are just touching the anatomical structures, in this case the kidney and the tumor. You feel it, and then you cut it, or you incise it with the scalpel and or other instruments. When you do laparoscopy, you are away from your target, and you are actually, your tactile sensation is being transmitted from the tip of the instrument towards your hand, and then you believe in your vision to adjust yourself to the depth and texture of the gland. When you are doing robotic, all these tactile sensations are actually lost. You have only your vision, which is a 3 dimensional vision in the case of a robot, and then you rely on it and you train yourself in order to understand the depths and surfaces of the target structures. If I make myself clear here at this point, then you will be able to understand that this is known as augmented reality. Now, the science moves from augmented reality towards virtual reality, and this is, at the moment, what we are doing is virtual reality. We are standing or sitting in a virtual classroom talking to you, you are talking to me. So when you are moving towards virtual reality, when the robots will have their autonomy and they will do surgery on themselves, but they require information given by us, the clinicians, and that information will be in digital form. Nephrometry score is one step towards that direction. So we can talk about this thing later in some other forum.
Okay.
So anybody else? We have got a little bit of more time.
I want to ask a question.
Ji.
Sir, in the previous slides, when he was mentioning about diagnosis, sir, you mentioned that in routine we do not do bone scan during RCC workup. So how we could assess the bone metastasis? Is it PET scan or anything else?
You see, there are different tumors in the body, but if we confine ourselves towards urology, then there are 3 big tumors. One is kidney, bladder, and the prostate. Now, every tumor cell has got its own affinity of metastasizing to one organ. For instance, the kidney tumor or the kidney tumorous cell, if it metastasizes to the lungs rather than to the liver. Normally, it can go to any structure. It can go up to the brain. It can go into the bones. But normally, it has got its own liking towards one organ, other than its own organ of origin. Same goes with the prostate. The prostate cell the tumorous cell will go to the bone first. It will go to the other structures later. Lymph nodes, yes, but apart from lymph nodes, it goes to the bones first. So we always do something called cost effective investigation. So whenever you are in the process of cost effectiveness, unless and until there is a strong evidence in history that one structure is involved, you don't do it as part of the routine protocol. If you come back to bladder tumor, now the bladder tumor patients, they have got uh, involvement of lung and liver both, but very less they involve the bones. So you can do anything from head to toe, but there has to be a stepwise fashion of investigation. These days, when PET scan is being introduced in our, say, in country, and particularly in the city of Karachi, when we have an SIUT, a PET CT scan without any cost, a lot of people do come in and say that I think that I have got a tumor and I need a PET scan from brain to any level, so that if anything goes wrong with me, it can be easily seen. Now, this is something which is not scientific. For instance, this is not something which is a part of the routine checkup, that maybe since I am 50 years old, maybe there is tumor somewhere in the body, so that I should be through PET scan every year. Now, this is not the way of doing the science. First, you have got the a doubt, then you have to look for the evidence, and then according to the evidence, you always manage your patient. So this is the way we should go about it. You can do bone scan in any case. You can do bone scan in kidney cancer, lung cancer, prostate cancer, maybe the bladder cancer, but the evidence should be there. Evidence is, for instance, if a kidney cancer patient tells you that I have got a very long standing backache, and I cannot explain why it's happening, and my orthopedic surgeon also says that there is nothing uh, different from your posture, there is no problem with your spine, then with the in the presence of renal tumor, you must do a bone scan, because maybe there is some focus.
Okay, thank you.
Yes, sir. Anything else? Right. So from today onwards, I have also posted this thing on the WhatsApp group. All these lectures and presentations are recorded and uploaded on our YouTube channel. I will post the link. You can subscribe that channel, and then you will all have the YouTube recordings. You can, if you miss something in this 1 hour uh, on a particular day, you can always refer back to the recording and just see it. The purpose is that everybody should be focused and learning and involved in the process of teaching. So if there is any suggestion, you can always contact me. Right. Thank you very much. And again, congratulations to Rafi and Abdur Rahim, who have done a marvelous job. Personally, I'm impressed with the style of presentation. It was something which is encouraging. Thank you very much.